So everybody, we have great privilege today that Mike Morse was actually able to come and talk to us live today. You would have heard his recording from last year in week 5, where he conducted the antibody identification workshop, but we've managed to garner his time for the next 2 hours so that he can give you this lecture in real time. So Mike is the scientist in charge of the Haematology and Blood Transfusion department at the Launceston General Hospital, and those of you who go on placement at the LGH will come under Mike's supervision at some stage. So without further ado, I'll hand over to you, Mike. Thank you very much.
Okay, thanks, Jane. So hello everybody. So I'm going to talk to you today about adverse transfusion outcomes, as Jane has said. My background, just so you're aware, for your own sort of interest, if you like. Originally, I was a scientist in the UK, so I trained in histology, would you believe, originally. So I spent 5 years doing that, and then someone decided that I would make a good haematologist and offered me an opportunity, and so I moved into that field. So whatever you decide with your career path, and that's it's a good and interesting opportunity for you to have a look at all of the things you do, just in case you go into one area and decide it's not for you. Don't necessarily give up on pathology, have a look at other options. My background is that I was trained in two of the biggest, one of the biggest trauma centres in Europe, which was the Nottingham Queen's Med and the City Hospital. So that was 18 kilometres of corridor and second biggest site in Europe. And Stoke Mandeville Hospital, which was my other hospital, which was the National Paraplegics Centre for the country, big burns unit there as well. So I've got extensive use of trauma and stuff, but we're going to be talking obviously about adverse transfusion outcomes and things. And so without further ado, I'll get into that. And by all means, if you've got any questions as we go along, Jane said she's going to jump in and rattle my cage if there's anything to ask, and I'm happy to stop and answer anything if you're not sure about anything. So when you go to your friendly neighbourhood transfusion laboratory, what do you ask for? So obviously our main products are fresh blood products, so our red blood cells, our platelets, our fresh frozen plasma, our cryoprecipitate. And what do you actually get? You get red cells, white cells, plasma proteins, anticoagulants, unknown substances in a nice cytokine soup. That's not available at Wolves by any means. So what are the risks associated with receiving these products? So we have viral, bacterial, allergic, immune, procedural, parasites, emerging threats, and the unknown. It's important to remember that although these things don't necessarily happen very often, they are frequent enough for us to have to keep an eye on, and we have procedures and processes in place. You can see there's quite a gamut of different things that can catch you out and be a cause of some quite nasty sort of side effects of anything that's either done by poor process or something that is was unpredicted, such as, like I say, a reaction to something. So if something goes wrong, how do we identify and demonstrate it? Obviously, we observe, we identify that there's something that's gone awry, then we investigate, and then we have to notify. So the first of those, observations. So the nursing staff complete these, so they have a blood product observations chart for each and every blood product transfused. So these are policies that in our practice. So they come under various gamut of procedures that are the local ones that are on the wards, but they're generally taken from standards that are national standards. The one that we currently use is Standard 7, which is to do with blood transfusion products. And so they've got lots of information to refer to, and the processes and procedures have to be adhered to for reasons that, as I said, will sort of unravel as we go through. So just a few little slides in there just to break up for you to have a look at. So we don't offer that service here, but nevertheless. Identifying the type of reaction. So basically we categorize these in two sort of main ones, if you like. So there's a hemolytic one, which is obviously the more serious one in many instances. So we have the immediate hemolytic transfusion reaction, so an ABO incompatibility. Thankfully, touch wood, we haven't had any in our establishment there, but as we'll unravel shortly, the potential for there is always there lurking in the background. This is why we have to keep a close eye on things. And then we have the delayed hemolytic transfusion reaction, which is to do with other antibodies which we may not have identified. Could be procedural, could be a process, could be the techniques that you use, could be the equipment that you use, so anything like that. And then we have the second list, which, although we would class it, on a sort of simplistic level as not as serious, there's still a potential for very serious outcomes. There's still potential for death on that side. So it's not something that we ignore. We don't just think, oh, it's not hemolytic, that's fine. We have febrile, which is probably one of our most common ones. Non-hemolytic transfusion reactions, so just a raising in temperature. Then we've got transfusion-associated circulatory overload, so basically too much volume of whatever products that have gone in. We have transfusion-related acute lung injury. As I said, we'll go into these shortly. Transfusion-associated graft versus host disease, and transfusion-related immunomodulation, which is something that's been talked about a lot, but is sort of the jury is a little bit out on the significance of it and whether it's a highly significant sort of adverse reaction. So the first one we have is hemolytic transfusion reaction. So potentially fatal. It's most commonly due to the transfusion of incompatible blood components. So usually red cells or plasma products such as your FFP or your cryo. Immediate hemolytic transfusion reaction is obviously at the time of transfusion, and the delayed side of that one is it can be up to 3 to 7 days after the transfusion. So we can actually give someone a product that they may have, say, for example, we've had an instance a few years back where someone had an antibody. We didn't know about it. It was in another organisation elsewhere. We scanned them. We did our group and hold, and we found nothing. And what happened was we then gave them units that, unbeknown to us, were positive for the hidden antibody that they got. So it's below detectable levels. So it hadn't been sensitized recently. So there was nothing that it basically dissipated out into a very low sort of titer. And what happened was, about 3 days later, the doctor who was looking after them noticed that the hemoglobin had dropped. So that's the sort of thing you can get caught out by. So don't assume that just because we do a group and hold that we can detect. Every method has a certain threshold. So these are things to look out for, and you would see when your day-to-day scientist job. So we're always mindful of these sort of things. So immediate hemolytic transfusion reaction most commonly occurs very soon after transfusion of incompatible red cells. Onset may be 1 to 2 hours, but usually within minutes. So, for example, if you have an O patient and you, as we've just done an RCPA survey, which is tests our sort of ability to identify these things. And what they did is we had a patient that did group A. We did a group afterwards on a post-transfusion, so they had a major reaction to the units that they were given during surgery. As I said, it's just a hypothetical situation with samples. They've had a reaction, we've investigated, and we found their second group to be O. So when we've gone through a period of analysis, what we've got there is basically the first patient was obviously not bled. It wasn't the same patient that was bled for the pre-sample. So these things have happened, do occur. And one of the reasons that we have, as you can see there from point 3, is close observation is required in all transfusions for the 15 minutes, is that first 15 minutes is absolutely critical. If you have someone having an immediate hemolytic transfusion reactions, you are going to see it very, very quickly. And it can happen from a few mil of red blood cells. It is a very small volume, and it will be a very acute situation and can escalate very, very quickly. So the first 15 minutes of a transfusion, there will be a nurse or should be a nurse at the bedside monitoring this sort of thing and looking for any signs of anything that is going awry. So that's our processes for all transfusions, as it says, that first 15 minutes. And this will, hopefully we don't have to see it here, but this will, in theory, if it's being monitored correctly, pick that up very, very quickly. ABO, as I've just described from that RCPA survey, is the most common sort of life-threatening event from that. So, like I said, as simple as a procedural thing, It's very rare for electronic systems now to be able to issue a wrong and incompatible unit to a patient because the system blocks it. So if it's going to happen, it's probably going to be where they have very little sort of access to computerized systems. But I think virtually in this day and age, everybody's got them, even in outback Australia. You can see when I go through these, the signs and symptoms associated with immediate hemolytic transfusion reaction, that these are fairly similar to the other reactions that you'll get. So it is very difficult to discriminate at this point, and we'll describe what our processes are. But basically, you get things like fevers, as I said, plus or minus chills, facial flushing, chest pain, back or flank pain, hypertension, abdo pain, nausea, dyspnea, which is like a shortness of breath, shock, vomiting, hemoglobinemia, hemoglobinuria, so your urine breakdown, anemia, transfusion site, general bleeding, urticaria, so like a rash or a hives thing, diarrhea, acute renal failure, and DIC, so disseminated intravascular coagulation. So you can see from that list, if you've got a sick patient, they might be suffering already from some of these things, so it makes it kind of tricky. That's why you have to know what you're doing, and you have to be able to, when you're doing this transfusion, you have to see you're looking for changes rather than what they've already got. But you've got to be very careful. Don't ignore something like if they've got abdo pain to start with, that there's not an increase in pain, if you like. So these are the things that the nurses are taught to look for. And so these are the things that we are expecting them to see, identify if there's a problem. So pathophysiology. So the underlying cause of immediate hemolytic transfusion reaction is the transfusion of those incompatible red cells. And basically, the hemolysis it basically occurs by the two mechanisms. So your intravascular, where erythrocytes basically are destroyed in the blood vessel itself, or extravascular, where the hemolysis actually occurs in the hepatic and splenic macrophages that are generally associated with the reticuloendothelial system. So two mechanisms, and that is, as I said, the release of that hemoglobin, certainly for intravascular hemolysis. For immediate hemolytic transfusion reaction is usually in that acute setting, so where the red cells are within the vessels, because that happens very, very quickly, as I said, and leads to nephrotoxicity, which is renal failure, which is why, if it gets too far, once you get that renal failure, it can be too late. The most common antibodies associated are anti-A, so, your ABO ones, as we've said. And that was the example I gave you from the Royal College of Pathologists survey that we do as part of our external QC. So they were looking to see that we could identify and work out what had happened. And then we've got usually your IgD ones, so your anti-Kel, your anti-JKA, and your anti-Duffy-A. And these are antibodies that basically bind to the complements, to the surface of the red cell, and they have a very, very efficient in vitro lytic properties. They get rid of those cells very, very quickly. So delayed hemolytic transfusion reaction. So this is most commonly due to an anamnestic or a secondary response in previously sensitized patients, as I described to you earlier on. So someone that we weren't able to detect initially because it hadn't been sensitized, probably hadn't infused for years, and basically it just dissipated into nothing, but it's still retaining the memory of the system. And when it was reintroduced, the antigen, then basically it ramps up and you get that reaction, but not necessarily straight away. And as I said, symptoms can be usually mild, severe, or even fatal, but that is, it is uncommon. Pathophysiology, as I said, onset is 3 to 7 days, so they may well have gone home by that time. And then one of the things that nurses do is sometimes when people have had transfusions, they're supposed to phone up. They certainly do oncology ward, and they phone and they say, any adverse reactions? Are you feeling unwell? Anything different to what you've had? And patient may well alert them to us. That was the case I described earlier on with the unfortunate lady with below detectable limits initially. And she became unwell later on and came in, and that's when they did the investigation. So, as I said, there are two types: primary sort of alloimmunization, which is usually extravascular hemolysis, and as I said, or the sensitization one. So it may happen, maybe something that is picked up very, very quickly or very, very slowly. It's often undetectable, as I said, it's unnoticed, and the patient may be at home. Again, you can see there's some common symptoms there again. There's the fever, plus or minus chills, anemia, mild jaundice. The rare ones are hemoglobinemia, hemoglobinuria, shock, renal failure, and DIC. And the antibodies implicated in these delayed transfusion reactions, you can see that, JK, Duffy, and Kell pop up there again, common ones. Anti-E, D, C, anti-M, and uncommon is anti-A1 and anti-P1. So it can be on anything. So you've always got to keep your wits about you in transfusion. Probably more so, definitely more so than the other departments, I would argue, but shouldn't be any less when you're doing your training. Hemolytic transfusion reactions must be detected and resolved immediately. That is true. You cannot go and ignore one and push through. So it's probably nothing. Give them paracetamol, they've got a fever, let's give them 1 unit, their hemoglobin was low, let's give them a 2nd unit. You may well be contributing to a very serious outcome. My cellar, thankfully, is stocked with much nicer brands than that, so some much nicer breads and things, but hopefully there's nobody's cellar around the country that's got anything like that going on. So we then have febrile non-hemolytic transfusion reactions. So what we do in these situations, so these occur, as I said, in approximately 1% of transfusions. So it's actually quite common. If you think that we probably, what do we say? We probably at this organisation, we maybe transfuse over 2,000 units. So you're saying about 200 units, you're going to get someone having a fever or febrile reaction to those units. It can be a rise in a baseline temperature greater than 1 degree C with no other medical explanation. So basically, we don't want to be giving transfusion to someone with a fever. That's really not going to work for us. That we do sort of advocate, if someone has a fever, you really shouldn't be transfusing them until they've settled down, because how are you going to know if they have a febrile reaction if they're already feverish to start with? So that is something that's potentially going to mask the problem. So what we're looking for is people who are basically stable, and then if they suddenly have a rise in temperature as the red cells or whatever make their way into the person's bloodstream, and they get a rise, then we obviously expect them to stop the transfusion and we investigate what's going on. They can be caused by leukocyte antibodies, so HLA issues present in the patient's plasma, and these are directed towards any donor leukocytes. This was quite a common thing as well, but we've gone away from that now. Most units are leukocyte depleted. And it could be, as I said before, previous alloimmunization of the recipient. So from a previous transfusion, pregnancy, you may have developed an antibody from baby that was in there. Baby's blood is over, and mum's developed an antibody to that. It's got into her system, red cells that aren't necessarily directly compatible, and the antigen is being picked up and produced an antibody. And obviously through tissue transplant as well. So, as I said, treatment, leuko reduced blood for subsequent transfusion. So all our red cell units now are leuko depleted. As I said, this is more of a common problem than probably you would appreciate now. But lots of people have minor reactions, or largely minor reactions to white cells. And now those have been largely removed by filters at the source in the donation centres and in the Red Cross. We don't really have a problem. And they're filtered also. There is a filter at the bedside to remove any residual ones that are in there. And the pre-medication usually takes place with antipyretics. I think it's usually like paracetamol that aren't going to cause any major dramas. We did actually have an interesting case many moons ago where someone from our oncology ward would be receiving a red cell transfusion regularly, so a couple of units every sort of like 3 or 4 weeks as the treatment progressed. And what would occur was every time they got to the end of the bag, they'd have a reaction, and they would send it up to us. And initially, we didn't find anything, and then it happened again about 3 weeks later. And when we did a full panel on it, we found that they actually had some white cell antibodies. So there are some BGA and BGB which were being picked up. And what was the reason behind that was, why were we not getting a reaction at the beginning, is basically there's so few white cells in there that the only time they were getting a reaction is when they were getting the entire red cell bag put through, and the few that were getting through were actually providing enough of a volume for the patient to react with. So that's why it was at the end of the bag. and not at the beginning, because there just wasn't enough white cells getting through for them to be having any kind of major reaction. But by the time they'd had all the red cells through, the volume of white cells that had sneaked through was enough to cause a reaction. So, as I said, you've always got to keep your wits about you, and there's always little things that will trip you up if you've not got your wits around. So, allergic reactions, again, quite common. Usually appear within minutes of exposure. It's an immediate hypersensitive type reaction, and the majority of reactions are mild and non-life-threatening. You can see that looks quite horrible to look at. That might just be literally a physical reaction, as in just one as appearance, but obviously they can present with things like itching and hives and that, which could make it very, very uncomfortable for the patient. And with these allergic reactions, they're possibly associated, as I say, with plasma proteins, donor substances, drugs and foods. So people with peanut allergies, for example, if their donor's been having a nice bag of peanuts on the day before that they're going in for their donating of their red cells or products, that may well find its way through into the bloodstream and cause a reaction with the individual. So you have to be very, very careful at both ends of the spectrum here, of both the donating and the receiving of these blood products, to try and minimise any ill effects. And these, as I say, are usually treated with antihistamine, and then there's usually notes made for pre-medication for future transfusions if they're able to get a handle on it, or at least if it settles down after that antihistamine. Then you go with things like transfusion-related acute lung injury, or TRALI. So this is down to anti-white cell antibodies in the donor plasma. So basically what you get is usually characterized by chills, cough and fever, and you get this sort of whiting out of the lungs that you can see. I mean, I'm not a radiologist, but you can see there's a marked difference between the two there. We get this whiting out and this haziness where you basically get respiratory distress issue around the lungs. So you get all the white cells, congregating in that area and having this reaction between those antibodies in the donor and the white cells that are actually in the individual. And that can cause some major problems. So cyanosis, so you're getting blue in the face, and hypertension, and people do have very, very serious reactions and have actually died from things like that. So it's very, very important to look out, as I said, for these sort of unusual reactions, and this is what that 15 minutes that we talk about and those regular observations are designed to do at the bedside. Then we have things like bacterial contamination. So that carries the greatest infectious risk, and most commonly it occurs with the platelets that we store at 20 to 24 degrees C. And it's common sense, really, if you think about it. Anything that you store at room temperature or close to 37 degrees, or closer to 37 degrees, should I say, you've all done, or you should have all done, the replication curves that you do from bacteria, and that they all thrive in those sort of circumstances where temperatures allow them to do so. So if something gets onto the bag or in the bag, then what it's going to do is proliferate. By the time it gets to the individual, it can cause a very nasty and potentially fatal reaction. So thankfully the processes are very pure, and that was very unusual to get one. We've had one actually in the last 12 months where the person had a very serious reaction to a bag of platelets, but it wasn't anything that we believe was introduced from within the bag. It may have been something that was on the outside of the bag, and that's why it's very important to maintain the cleanliness. And you all have been very used to that now with COVID, and cleaning your hands and washing your hands. If nothing else, it's given us a reminder of the importance of cleanliness. And as I say, it's usually due to skin flora, so it's introduced from the skin. So they have you probably noticed when you donate, they wipe the area that they're going to insert the needle for your transfusion your donation of red cells and whole plasma. A whole blood product, sorry. And what they do now is they've got a skin diversion pouch. So initially what will happen is anything that's in the outside will be hopefully protected. And the first few mils of blood that come out, so potentially that will be in contact with anything that's on the surface of your skin, will be diverted away from the bag. And then after that, you should be getting everything from internally rather than anything that was introduced from on the outside of the skin. Unfortunately, as you know, or you'll get to know if you don't already, the people that have platelets generally are the ones that can least afford the challenge. And I would argue that that's probably the same for all blood products, and that most people that have blood products are ones that are immunocompromised. A few obviously post-surgery blood loss, things like that, but generally our regulars, if you like, will be the ones that are fighting disease and in oncology wards and so like. So it's really, really important, especially in those areas more so, that these sort of things are adhered to, and cleanliness, etc., is fully approached in the right manner. So bacterial contamination, I said platelets is a common one. Incidence is low, thankfully. Rapid onset, potentially fatal, and most commonly it is this one you've seen here, enterocolytica. I haven't seen one here, thankfully, and that's not one we want to see either. But as I said, it's they are there and they're in the background, and we keep an eye on everything. Then we have transfusion associated, so graft versus host disease. So this is caused by a proliferation of the donor-derived T lymphocytes in response to exposure to the patient's antigens. So unfortunately, there's no effective treatment to that. We do corticosteroids prevention, so that's the idea is there to basically build up the to dull down the immune response on that. So there's very little chance of anything going on there. And so what we end up with then is irradiated products as well to remove anything that hopefully is in the donor side of things that can be introduced into those people. As I said, these are people that are generally very sick, and so we don't want to introduce something onto this that is going to make their situation much, much worse. Signs and symptoms, as I said, usually detected 3 to 30 days post-transfusion. Pancytopenia, so your red cells, your white cells, and your platelets all low, fever, elevated liver enzymes, watery diarrhea, rash, and desquamation, which is basically, some of your skin starts peeling away and such like. So, thankfully, again, rare. It does carry significant risk and potentially fatal. So, 84% of cases, once that takes hold, it is something to be very mindful of and obviously observed, and it is very important that, as I said, that in these individuals that we take as much care as possible. And we should take care in all situations as well. I'm not just highlighting this group. I mean, this is when you work in the medical health care background, you really do have to be, a virtue of cleanliness and such like, and procedures, and wear gloves and such like where appropriate. So it's important to do that for not just for what you think in the lab, but where this product's going to end up. And the at-risk groups, as I've said, is the lymphopenic patients, the bone marrow suppressed patients, the fetuses receiving intrauterine transfusions, and newborn infants receiving exchange transfusions. And then we talk about TRIM, which is immunomodulation. So this is basically transfusion-related suppression of the immune system. Renal transplant recipients are transfused for the effect. So the idea is that any immune response is sort of dulled down by the sort of a volume, if you like, of the donor, the red cells and whatever that are put in there. The issue with this is it's very difficult to prove with that, because, as I said, it's something that is something that we would necessarily investigate. So there are issues around that. Some believe in it, some don't. The problem is here you can get higher rates of post-operative infection, you get increased length of stay, and it all costs money. And unfortunately, as you'll find out when you go into laboratories, it is something that money drives a lot of things. We do have a fair degree of practicality and, shall we say, some flexibility in our budgets and such like. But at the end of the day, it's much easier to get something over the line if it costs a lot less. And if you've got a treatment that's going to cost a lot less, you're obviously going to get one as long as it's just as effective. And so this is something that comes up regularly, and just be mindful of that. And then we have storage lesions. So these are red blood cells that are altered with prolonged storage. As I was talking to Jane, if you were in at the beginning before we started the lecture, we've been very good at shifting our stock. We don't sit on our red cells and products very well. We used to. As I said, we used to throw out lots and lots of red cells, but we changed a lot of our systems and that to improve that. And so this is something that's generally we have. We don't generally have red cells that are expiring on the last day, you know, on the label that we transfuse to patients. Usually they're gone 3 or 4 days at the worst case scenario. So it's we do sort of move our stock around when we're moving them forwards and backwards, so they are getting some movement in there. So just letting them sit there is where we get these problems. As I said, it's clear what impact these changes can have on the ability of the red blood cells to release oxygen, and what impact this may have on the patient outcomes. So you basically, what you get is a stored red cell. They certainly develop membrane damage because they've been in there so long. You know, obviously it's like all of us getting older and getting damaged as we go. So if what happens, you get a change, it leads to an increased membrane rigidity, as it says there on the slide, and reduced deformability. So it makes it very hard for them to go into all those microcirculation red cells. So you don't just have major vessels that feed your organs, you have all that microcirculation that works all the way through your body, and obviously all those parts of the tissues and everywhere where you actually get that, where you need oxygenated blood to get your cells to rejuvenate and to function properly wherever they may be. And stored red cells also have reduced levels of the 2,3-diphosphoglycerate, again, which is it's all to do with the release and take-up of oxygen. But again, the potential effects of this on the oxygen transport are controversial. So nobody really does any major studies on this, because at the end of the day, you know, that we get the donor cells and we basically use them the best way we can. And you know, with the problems with donation at the moment, it's really, really important that we don't put too many adverse roadblocks in there and worry about how long they're being there. We do try and basically to use up everything built from the Red Cross. If you're donating blood products, you don't want to find out that it's ended up in the bin. So it's really, really important when we look at these things that you know, that we know about them, we're aware of them, and we try and use our stocks the best way we can. And as I said, because it's controversial and because it's sort of out there, it probably shows that it's not black and white either. So then we step into viral, so, you know, your HIV, your AIDS, you know, human immunovirus, transfusion-associated hepatitis, HTLV, human T-cell lymphotropic viruses, your West Nile virus, other viruses, CMV, EBV, parvovirus, human herpes virus, and the emerging pathogens around the world. Red Cross a lot of viral testing and stuff now, so they've taken a lot of the things like hepatitis and HIV out of the equation, but it doesn't mean that they can't necessarily sneak through, which is why they do on the questionnaires a lot of things around with the donors, their practices, you know, either drug use or anything like that. They look for signs of that to make sure that something doesn't develop in the process of them receiving the blood unit, sending it out and giving it to someone, and then finding out later on that they've actually developed hepatitis, or, you know, due to some other practices or whatever, they've developed HIV or anything like that. So it's really, really important that the donor is very honest about it all as well, and doesn't, you know, increase the chances of the risks. And I'll talk about something shortly around that, exactly what I was talking about just then. Procedural carries the greatest risk. Patient identification, wrong blood in tube. Believe it or not, that occurs more often than we'd like. So basically, a patient is bled on the basis of their badge, and we've done a lot of work around that as a hospital and as an organisation. So we have registered staff now that go around rather than expecting the nurses to do it on top of their duties. Very easy for a nurse to get distracted on a ward and have a name in their mind. Someone says so-and-so is having a cardiac arrest, for example. They're taking the blood of John Smith, and Julie Jones down the road is having a cardiac arrest, and then they come and label the blood, and they know that something's going on and they label it Julie Jones. It does unfortunately happen. It's as easy as that. And it's why we've basically tried to take those procedures away from the nursing staff. My mother bled patients for 30 years. She was a phlebotomist in the UK. That's all she did. I don't believe to this day that she ever did a wrong blood in tube. And she failed to label one tube once with a patient's name. And she talked about it even in her retirement. So that's the sort of thing about attention to detail. It's a very, very important process. She understood that. It's not that nurses don't, but then, you know, duties get diversified, And really, you really got to have dedicated people who do that to do the job and not have anything else to worry about. So it's a very important part. Seems very simple, but it's a very, very important part. And as we say, carries the greatest risk. Wrong blood collected from the fridge, that doesn't generally happen. It's important to come down with the correct identifiers, proper labels and stuff, not just, oh, can you go and collect the blood on Jones? Could be 3 or 4 Joneses in the fridge. It's important that you have the correct identifiers and the person collecting knows the importance of signing out the correct blood for that person. Sample error in the laboratory. Could be someone's put the wrong barcode label on it, someone's booked it in incorrectly, and stuff like that. So again, we have to always have our wits about us and check the scanned image against the sample that we're authorising, whether that be haematology, chemistry, transfusion, and blood given to the wrong patient on the ward. So no bedside checks, just assume that the blood that they've got for Jones is the right Jones, and someone goes ahead and does it. They've got to make sure that what's on the bag matches the patient label. There are numerous reports that are available that are around the world where those procedures haven't been followed, and that's where the catastrophic failures come, human error. So that's why a lot of our processes are laboratory system processes with computers, so it takes a lot of human error out of it, scanning barcodes, so providing that's all being labelled properly, scanning barcodes, scanning barcodes on blood bags, scanning barcodes by patient bedside. So this is all designed to cut down these errors. As it says there, all failures to follow procedure. So as I said, other risks, so transfusion-associated parasites, someone with malaria maybe, transfusing or donating blood, could be something in there, could be something else in there. Prion diseases, so, the Creutzfeldt-Jakob disease, none of us knew about that. Emerging diseases, COVID. What impact of COVID on blood products? They're talking about treating people that have recovered from COVID using their plasma. We're part of that trial, but we don't have any cases down here, thankfully. But people who have recovered from COVID using their plasma, has donated plasma, using that to treat patients with very, very serious COVID symptoms and, on ICU wards and that. And we hear about all these people saying that, there's 2 schools. There's those that are obviously very worried about it, and there's those that say it's all a big myth and it's all overplayed and over the top. But speaking from someone who had a friend of theirs, or a friend of mine, sorry, my family die from COVID in Spain, literally a week before, commenting on something on my Facebook post, and then reading his obituary from life, sadly, on Facebook. It's not a gain to us, certainly in the healthcare profession, and there's a lot of work around that. So there's a lot of work being done in that area. We are very mindful. We get a lot of literature from the Red Cross about COVID and what they're doing to make sure that their donors aren't literally infecting other people if they don't know they've got symptom, being very, very careful. So it's a big unknown for us. So that would definitely class as the emerging diseases. So, and as that saying says, you don't know what you don't know, and we don't know. That's the thing. So we don't know what the risk is of giving someone that through a transfusion, but they're doing the best they can to alleviate that problem. I think that probably counts as the next HIV at the moment, and it's certainly part of the World Health Organization global monitoring. So interesting times. And as I said, I touched on it earlier on with HIV being the French contaminated blood scandal. I'm just going to turn my phone on so I can read you something which was associated with this. And basically, this was a case in 1984-86. A former French Prime Minister and 2 of his fellow ministers have gone on trial accused of the manslaughter of 5 people who died after receiving transfusions of tainted blood. Now, why are you blaming politicians and that? But when you look at the background to this, it's absolutely horrific, and gives it's probably a sad indictment of the times we live in. That certainly a lot of politicians value their own place and their own job over those with the responsible positions that they have over the well-being and the safety of those around them. And this is a very, very extreme. And I'm not all politicians, by the way. I'm not generalising. I'm just saying that there are many that are, unfortunately, that are in it for themselves. And this was a very, very horrific thing that happened in 1984 and 86 with Laurent Fabius, where his colleagues were accused of being responsible for people contracting AIDS from blood transfusions contaminated with the HIV virus, and 5 of the 7 died. The deaths here were far higher than that. And if I read you an article from that time, and basically what it said was, I'll just give you a bit of a briefing. So, former Prime Minister unlikely to be found guilty was the headline, as per someone else has to take the fall and everybody blames everybody and no one will pin anything down. So, former Prime Minister was charged with manslaughter for his part in a scandal involving supplying HIV-tainted blood to hospitals. And basically, it said that the trial looked set to absolve all the high-level politicians. Notice it says high-level, not politicians. High-level politicians charged with responsibility for one of the worst man-made health disasters in France. And the prosecution admitted the collapse of their case on February the 24th. And basically, what it was the scandal erupted for the first time in the mid-90s. By 1985, all the supplies of blood and blood-derived products held by the National Blood Transfusion Centre, the CNTS, the organisation responsible for collecting and processing blood, were revealed as contaminated with HIV. That's all the supplies. Okay, so around 4,000 to 5,000 French people, many of them haemophiliacs, were infected as a result. To date, estimates are that 625 out of the 1,348 haemophiliacs infected had died, and this figure is destined to grow. So there was never any follow-up, as far as I could see, on that. But you can see those that required, those high-intensity blood transfusions then found themselves infected with HIV when they had major bleeding episodes. And basically, what it came down to was, in 1983, the American pharmaceutical company Abbott applied to have their AIDS screening test. So remember, AIDS was a big thing in the late 70s and that. So this American company Abbott applied to have their AIDS screening test patented for the French market. But this met a barrage of opposition from their French counterparts. So Diagnostics Pasteur, who had their own screening test, but it was still under development. So let us quote. Sorry? I'll carry on, sorry. So letters quoted by Le Monde newspaper show the role played by the Health Secretary and the Prime Minister in deliberately delaying the patenting of Abbott's test. So what they were doing was, the French had something that they were working on. The Americans already had something that was ready to go, which would do their screening test and would have identified these donors. And then what's occurred is the French politicians deliberately held it up in order to make sure the French test got over the line. So there's that lag gap in between where nothing was getting tested properly. And so all these people were donating blood who were HIV infected, none of them were picked up. And it says that in 1983, Diagnostics Pasteur, the French firm, applied for a patent in the United States, which was only granted in 1986, so 3 years. So the systemic testing of all blood donors for AIDS was recommended by the World Health Organization in 1985. So there was a whole 12 months there when nothing got tested for HIV. So what you basically ended up with was these people were basically hung out to dry and left and abandoned with a complete lack of regard for their well-being. And what happened was that the CNTS also continued to collect blood from categories of donors or from areas considered to be more likely to have HIV-positive donors, such as prisons. So 10% were estimated to be drug addicts. So you can imagine the massive, massive risk that they were going to, and they were blindly going on. CNTS also refused to import blood to offset a situation of temporary scarcity. So everything was building up and building, and they were just adding to the problem with every decision they made. It took 8 years after, it was not until 7 years after the scandal broke out that Parliament first passed a law creating a compensation fund. But what's a compensation fund worth to someone who's got a dead relative? It took another 8 years to compensate 3,846 victims of their families. And the true number was not yet known. So it was just an absolutely disgusting, basically scandal that broke, and caused so much harm and so much, and really was just not the way to deal with any pandemic or any sort of issue that you would, say not pandemic, but certainly a way of dealing with people that rely on those blood products being very, very safe and not worrying about it when they go and get these donations. So basically, sorry, yeah.
It's okay, Mike. I thought you were about to head on to the next section, and I'm just looking at the time, and I thought this is quite a good time to take a break, but please finish what you were saying about the French scandal.
Yeah, but basically, as I said, after many attempts to cover up the implications of this scandal, several trials took place after 1992 that saw some high-ranking civil servants sentenced to jail. However, all the senior political figures got away with it, basically. The formula generally used by the courts was to declare some lesser political figure responsible but not guilty. And basically, the whole administration was let off and were given the benefit of the doubt on the basis of a lack of information or the poor state of knowledge of AIDS at the time. Totally reprehensible way of dealing with it. Just showing you how important it is that we do all our processes correctly, that we do everything as we should and correctly, and follow the guidelines for the patient's well-being at all times, and including our donors too. So I'm happy to take a stop there, Jane, if anyone's got any questions up to that point.
Sure. And one of our students has got a cat who I think is going to have to end up getting a pass for transfusion science, because Franklin the cat, he always seems to be quite fascinated by transfusion science. So that was the noise that you heard before. Has anybody got any questions for Mike before we take a 5-minute break? I guess I've got a comment, Mike, and that's, what's happened with this French scandal, not wanting to use the Abbott testing kit over a local French kit has a lot of resonance these days with our race to find a vaccine for COVID-19, doesn't it? So it'll be interesting to see how that plays out.
Yeah, absolutely, and I've read the literature that I've been able to see, Jane, certainly with the vaccines and stuff, and I've already got an opinion of my own that I spoke to Danielle, who to the other people in this room, that in the virtual room, if you like, is also a scientist, my wife, and what we've read. The Oxford vaccine, that to us is not the perfect answer to the vaccine. There are some Australian companies doing some interesting things as well. Whether they get that right before we actually get this out, it will be very, very interesting. But you're right. I mean, we shouldn't be picking one based on where it's come from or for our own political gain. We should be picking the best thing that comes out and is developed and is the safest, and will have the best end result. So it'll be interesting to see with all this big race to multi-million-dollar vaccine, the potential for them. This will make firms rich to their wildest dreams, really, if they're looking at it. It's sad that that's probably their motivation, but the reality is someone's got to develop it. It's going to cost money, and we'll be interested to see what actually happens.
Yes, it will indeed. Okay, so we might take a break there, people, and say if we take a 10-minute break and come back at 1 o'clock, that's going to be good. And then, Mike, that gives you a chance to duck out and check and make sure that everything's okay too.
We're all still alive out there.
So if we meet back here at 1 o'clock, people. Thank you.
Yeah, sure. All right, thanks.
Okay, is everybody back? Looks like we are. Mike, are you there?
I am.
Excellent. Okay, so let's continue on.
Okay, so transfusion reaction investigation. So as I've alluded to earlier on, all adverse events associated with a blood transfusion must be evaluated and resolved. If there are any adverse effects, what you cannot do is continue on and assume that it's just a mild reaction or just a mild sort of adverse scenario that's playing out in front of you. It needs to be properly investigated, especially if it's on the back of the reaction occurred as and when you started transfusing or infusing patient blood products. And how we go about that is, certainly from a laboratory point of view, is we do a transfusion reaction investigation. So as I said to you earlier, we did an RCPA survey, and we do regular RCPA surveys, including myself, to test our skills and our knowledge and make sure that we can pick up these problems. And this is basically what they're testing as well as our procedures and processes to identify the issues that we've got with that scenario. So in this case, if we get a transfusion reaction investigation from the ward, we do a clerical check. We do a visual inspection of the samples and blood bags. So we're looking for any signs of maybe something with FFP or say cryo, or some cloudiness in there. Is there something that's been growing in the bag, for example? We check our samples and have a look, see if there's any signs of hemolysis in the plasma after we've spun them down. So these are the sort of things we do. So we do a serological check as well. So we're doing our group and our antibody screen. We're doing a direct Coombs test if necessary, just to see if there's been, certainly on the post sample, see if there's been any sensitization event picked up. So we're investigating that. We do our donor bag checks to make sure we've got the donor is matching up with the patient. So we do all these things. We send the bag down to micro as well, so make sure there's nothing being grown in it. We do blood culture on the patient as well to see if they've got something that's been picked up in their bloodstream. So if they got something that's been either picked up from the bag or something that so happens to have been, started up on them that we didn't know about before. So some kind of issue. We do our full blood count, so we're looking for any signs of hemolysis, so our HB dropping, for examples, or DIC, so with hemolysis breakdown of red cells. We do a urine as well, so to see if there's any red cells showing up in that, and obviously our bilirubin as well to make sure we're concentrating on the hemolytic side of potentially that transfusion reaction.
Mike, just before you go on, would you be able to just briefly outline what your clerical check involves, please?
Yeah, sure. So the clerical check that we do is we're looking at full name and correctly spelt as well. And I'll allude to that later on with one of the slides, but we're looking at the full name, so first name and surname, date of birth, and obviously the THCI number, which is the unique 9-digit number that everybody in this state has, or will be given if they ever come into a hospital setting. So you'll be given a unique number which will identify you uniquely against any other person on this island, or anybody that happens to come in from the mainland. So those will be the checks that we do on a clerical check, and we basically cross those with the request form that we've got to make sure that everything matches and is exactly correct on the blood tubes and on the form as well. So we then move on to reporting. So looking, all our sort of reactions or adverse outcomes are reported in the terms of the central events, so the deaths, state and the federal regulatory bodies, and also to the coroner, to medical officers on the wards, to our blood transfusion committees. So we have a hospital transfusion committee here, and we also have a generic blood management committee that we report to as well, which is for the state. So that includes the Royal Hobart Hospital and the private laboratories as well, like Hobart, the Northwest, and the Mersey. So we all report things together, and we also report them to our professional notification bodies, such as STIR in Australia, which is the Serious Transfusion Incident Reporting, and the SHOT one, which is the UK one, which is the Serious Hazards of Transfusion. So part of that transfusion surveillance, if you like, with these reports is, as I said, there's an openness to report things what you should never do, and what we're trying to do here, is we're reporting on the basis of an honesty and having some honesty, professionalism, and integrity. People make mistakes. It's a sad fact. I make mistakes. The people listening in on this lecture will make mistakes. Jane makes mistakes. What we have to be sure that we do, where we've made a mistake within our profession, or where something has gone wrong, or where we've had an adverse outcome, is that we report these things to the National Blood Authority, because this will lead to is better processes, better procedures. It will alert us to any potential things that are lurking, like we said, those emerging outcomes of diseases, emerging diseases, where if we report something and we think, oh, there's nothing of it, and then someone else reports something, you know, in another hospital, and then someone else starts, and then they start collating the information, then this is the way we can fix these things and sort things out. Burying it, if you like, probably an unfortunate title when you consider that some of these patients die. But if we bury those sort of things in the background, then we're not getting to the bottom of issues, and we're not fixing them. So it's really, really important that we learn from our mistakes rather than try and hide from them. And this is what these sort of reporting organisations are. It's not about hanging you out to dry professionally. It's about seeing what happened. Did you go away from a process or procedure? Did you do something? And really locking them down into making sure that doesn't actually happen again. So, as we said, or I've said there, hemovigilance is blood system surveillance to gather, detect and analyse system errors and the adverse effects of transfusion, with the aims of making transfusion safer and maintaining confidence in the blood supply. As I said, learning from our mistakes. And what you end up with these hemovigilance report summaries, if you look at that there, you can see there that, you know, we've got these sort of numbers. I don't know, can you see my mouse on the screen there, Jane?
I don't think we can, Mike, but up in the top left-hand corner, there's a pointer.
There's a finger pointer. Hey, this I'm learning. See, this is what I mean. Learning things all the time, even at my age. So what we've got there, can you see now? No?
No, it's still not doing it. I'm not exactly sure why.
See something now?
Yes, I can see it now. Yes, there it is.
There we go. So I'm already fully trained now in the art of pointing on a slide using virtual reality. So what we've got here, if you look at these sort of numbers here, so as I said to you before, the febrile non-hemolytic transfusion reaction is the most common at 52%. You've got your severe allergic reaction, which is 25%. And then you've got, so you're really looking at what, 77% there are made up. Those are your adverse transfusion reactions, if you like. Thankfully, things like our acute transfusion reactions, hemolytic transfusions, are not delayed, make up about 3%, but it's still 3% too many. And you've got all these sort of things like incorrect blood transfuse. So that could be, for example, a platelet or an FFP instead of something else it should have been. You can see they make up 6%, anaphylactic 4%. So basically what we're doing here, if you look at that, you can see there that the majority of them are these basically temperature rises or allergic reactions that you can't really expect to happen. They're not something that you can pre-plan and say are going to happen. They're just unfortunate circumstances. So a lot of the other stuff is preventable. I would argue that transfusion-associated cardiac overload is probably preventable, but Trali isn't. You wouldn't necessarily pick that up. And your transmitted infections. So these are the ones that you'd probably say about 5 to 10% in there are things that added on to that top one. So really looking at 3 to 5%, ones that we really are the ones we've got to be looking out for, that are things to do with detection and our processes and procedures to a large degree. And you've got 6% there as well. So say 5 to 10%, as I said, the ones that you can probably do something about. And you're probably looking at these numbers here, and you see that you've got like 154, 158, and in 2010-11 is 321. Now you think to yourself, oh God, we're getting worse, we're getting more reactions, obviously a lot more. It's double the amount of numbers, double the amount of numbers, from there that we're getting. And the reality is here that what happens is you bring in these hemovigilance surveys, and people are very suspicious. They're thinking, oh, it's a blame game. It's the nature of human behaviour. Is why do they want to know? What are they going to use this for? They're going to use it to beat the profession up. And what happens is then people get trust behind what is actually being reported and see some benefits and say, look, this is what's occurring. There's new recommendations that come out now to stop this from happening. And then people start to willingly share their information and realise that this is aimed to fix things, not to exaggerate or to extrapolate information out to play a blame game. And that's really, really important. And it's something that you will learn when you do surveys and put stuff in, that it's all to do with learning. Or in the majority of cases, it's to do with learning. So they make for very, very interesting reports when you look at them these days to see what's still occurring, what's out there, and what's a problem. Thankfully, I have to believe that my 6-year-old is probably at this sort of level now here, where he is experimenting with things, but hopefully not on the front of a plane. So, yeah, you can see safety is expensive. And this is why we put all these processes and procedures in, especially in America. They're very keen to sue people for the slightest thing that goes wrong or to play the blame game. Sometimes there are people at fault, sometimes the process is at fault, sometimes it's just one of those things you couldn't really avoid, but unfortunately that's not really discriminated against when the motivation is getting money out of a situation. So as I said, it is expensive. We don't want to get wrong transfusions. We don't want to get wrong. We don't want anyone getting sued. And so it's really, really important, not just from a monetary thing. Obviously, much higher up that scale is the personal side of things as well. We don't want to kill anyone, just ultimately, or cause them some serious harm. So, as I've sort of alluded to there, the hazards of transfusion, the common misperception is that the viral infection carries a greater risk. Your hepatitis, your HIVs, but it's actually not. The greatest risk to patients having a blood transfusion today is that ABO incompatibility, and that's due to systemic human error. And what we had was, the way it used to be was that doctors requested cross-match blood for patients. They were trained and skilled. Laboratories provided highly tested compatible blood. They were trained and skilled. And then junior doctors and nurses transfused the patients, and they were untrained and uneducated in transfusion medicine. So it's not that they were untrained and uneducated in doing their job. It's just that transfusion medicine, we didn't have much of a setup where we were actually educating them on what we actually do and why we do it, and what that has as a knock-on effect onto them in their roles on the wards. And we've put a lot of things in place now, like transfusion nurses. So we have a transfusion nurse here who is our connection between the laboratory and the nursing staff and the clinical staff. We have clinicians, haematology consultants that now do a lot more training along those sort of lines and make those links as well, and are much more readily accessible to answer questions and queries. And so there are things that are being put into place to fix this thing down the bottom here for the untrained. As we said, untrained, it sounds untrained and uneducated, sounds a bit of an insult, but it's literally to do with the transfusion medicine, bringing people awareness into what they should be looking for and why. And then you can see here, and this is where this human business of why there's so many issues around this. So it's such a high risk. A blood test, you identify the patient. Result, you're correctly identifying the patient. The review of it, you're correctly identifying the patient. Request, identify the patient. Every single one of those: sample collection, sample labeling, transport to the laboratory, labeling in the laboratory, blood group, antibody screen, cross-match, collecting blood from the laboratory and transferring remote fridge or ward, placing in the remote blood fridge, collecting from the remote fridge and transport to bedside, and transfusing blood to the patient. There are so many identification steps on there, so many steps in that process. For me, doing this, it's a very quick sort of system. It's a very quick, so I do it every day, I'm used to it. But each part of that chain, everybody has to know their role and to know their checks and to do those checks in order for it to work appropriately and for these mistakes to not occur. And unfortunately, they do occur, even here at certain places. So I can probably give you, or not necessarily an episode, but I certainly remember in virtually every single one of those situations of something not being quite and leading to an issue or an error or something, usually not without any serious consequences, but sometimes we do pick up on things after the event, but thankfully nothing fun. Hopefully we're not going to get anything fatal, but it just shows you how many links in that chain, of events that you can literally pull that up at so many different levels, and why we rely on the professionalism and the thoroughness of people in every part of the process and in every profession within our hospital scenario. And as I said, you recognise the hazards that recognise the consequences. So, the wrong patient bled, potentially fatal. Sample incorrectly labelled, potentially fatal. Faulty sample, potentially fatal. Wrong blood collected from the fridge, potentially fatal. Wrong patient transfused, potentially fatal. There are so many steps and so many consequences of things that that can be absolutely horrific outcomes. And that's why it's important that we follow our processes and procedures as laid out. They're basically, as I said, set up from what has gone wrong before. So it's not that these are new things; these are things that we've learned from. So how do we avoid these problems? As I've suggested, gathering and sharing of information. These notification boards do that. They let us all know what's going on and what's going out there. Reporting of near-miss events and errors. So no blame game. We just go out there and we say this occurred today, and we have to come up with a review, which is what we do. We educate and we do promotion of best practice. So when we make errors and stuff, not only do we report them to our regional bodies and our professional bodies, but we also report them within our safety response and learning system, which is called the SR system in the hospital. So everyone that's in a managerial role can see what's happened somewhere else. So we don't try and hide behind that. We have to hold our hands up and say if we're at fault. Likewise, we rely on people to report them. Not everybody is good at doing that. So in some cases, we have to report for others and say that you need to tell us what's gone wrong. That is what it is. It's an open system where we're not down to again. We have to review it and say, well, how did this go wrong and how do we stop it from happening again? As I said, serious hazards of transfusion in the UK system was launched in 1996. We've got STIR over here. So the aim is to collect data on serious events of transfusion of blood components, and this was done to improve safety, inform policy, and aid in the guidelines, which we have. And the shock reporting, this is obviously a few years old now, 6 years old, but you can see again the events that show up on what we're concerned about here. But there's things like handling and storage errors and incorrect blood component transfuse. So I said giving platelets say for someone who's got a coagulation abnormality, who's bleeding. Even giving the wrong anti-D dose, avoidable or under transfusion. So, and then we've got our hemolytic transfusion reactions, and then our acute transfusion reactions. So you can see, you look at that and you see 350 events. You've got to remember that the population in Tasmania, I'm not downplaying that by any means, but the population in Tasmania is 500,000. The population in the UK is roughly about 60 to 70 million at the last time. So you're going to get more events, and unfortunately more exposure, more pressures in the system, more breakdowns in those procedures that I showed you, all those things, those steps that need to be handled correctly. And then unfortunately that is an outcome of there. So, there are some big numbers in there, sadly, and but that's something that they're working towards and trying to fix. And the only way you're going to do that is by fixing issues and by confronting them head on, not hiding them. This is a report from 2017, and you can see there that when you're having a look at stuff there, so we've got hemolytic transfusion, we've actually got 42 near misses. Look how many near misses were there where people have thought, oh, they've picked up a problem. So somewhere in that chain, someone has done their check and gone, hold on a minute, that's not right. So you can see these are numbers. That's there is a it's not so much a congratulatory thing, but that's a sort of an advantage, knowing that your process to a large degree is working, that you've managed to get those checks in place, and every one of those that's a near miss that someone has picked up is basically a pat on the back for someone following the procedure and process as laid down. What happens is when you get to this sort of area where you're getting them going through, like things like, I'm just going to have a quick look. So the anti-D immunoglobulin errors, this is where errors occur where people aren't doing the check. So I might issue the wrong one, someone upstairs, so I'd say a small dose, a 125 dose, or 250 dose, international units of anti-D. Patient requires a 625 international units. I issue it to the ward, the nurse signs it out, doesn't notice it, gives it to the nurse at the bedside. Nurse at the bedside just says, oh, the lab never get it wrong, doesn't check, injects that person, and they have got the appropriate anti-D dose for their circumstances. So it's things like that. Whereas if someone catches that error and tells me, as much as I might be annoyed that I've issued the wrong anti-D, it's been intercepted and the process is there. And it's a wake-up call to me and to my colleagues that we need to know. And likewise, we know then that the checks are being done at the bedside. So I'm always grateful. I hate making mistakes, and so do my colleagues. But if I do make a mistake and someone picks it up, I'm always going to be grateful that someone does and that there's no serious outcome. So this is what you have to get into your mindset. One of the things I teach my staff, and I tell them about And I've never had any problems. That I say to them, don't ever lie or try and cover up what you've done, because we can fix things that are actually fixable, this and processes and procedures, and it might not be that you're wholeheartedly to blame for this. There might be something that we haven't fixed and we need to sort out. So maybe a double check or something in a certain circumstance. So that's why I make the point to you is that it sounds funny to say don't lie. You say that to children, but adults do sometimes because they panic and they do things. I haven't come across that here, but I am aware that it has happened in professions, not just in healthcare. And it's important to just be honest and come clean. And I would say, if you do take anything into your job life, make sure that you do that regardless of the consequences, because it can be far worse if you do the other. So if you look at this here, shots 2017 part 2, you can see here that the deaths and morbidity, so we had 15 deaths and 52 major morbidity and in between the period of 1996 and 2005. And although we're reporting more events, you can see that it's actually gone down. And that's because they've closed the loop or closed the problem areas and brought in guidelines and updated and improved and made things much tighter and much better. And we've become much better at doing it. I mean, it's still too high, that number, but the reality is that we are putting processes in place to fix these issues. So in Australia, we have the National Blood Authority, which I was talking to at the beginning, who oversee all our blood products and use of them and our ordering and set our budgets and such like, and Red Cross, who actually supply the blood products, collect our donations and do all the safety checking and testing. And then we have the NHMRC, which escapes me for the time being what that is for guidelines, but they produce some clinical practice guidelines on the use of blood components. And then we have the ANZBT, which is the Australian New Zealand Blood Transfusion Society, and they do guidelines for pre-transfusion testing. I've got 2007 in there, so Jane did give me a hint that I may have been out of date with it because it says 2011 on there. She's quite right, that's been updated now, and that's 2019 and 20, so slap on the hand for me. But these guidelines are regularly updated and put forward, and so they are basically best practice now and normal practice. So thank you, Jane. National Health and Medical Research Council, there we go. So I don't use that very much in that setting. We're usually using more of our ANZSBT and our MPAC, which for accreditation purposes to make sure we're following all our testing and procedures. But these guidelines are much more updated now. As I said, we participate in better, safer transfusion side of things, but that's no longer around, and now it's been replaced by a group called Blood Matters, which covers Victoria, Tasmania. I think it still covers ACT and Northern Territories, but all the ones I see are from Victoria. And obviously our serious transfusion incident reporting system, where we will put things into that system where we've had some adverse sort of outcomes or adverse ability to follow processes or procedures. So that all goes in there, and we have to be honest about that. The way we pick these things up are by audits sometimes. I mean, sometimes people will come up and say, oh, I've made a bit of a boo-boo, or I've made a mistake, Mike, and they'll come and tell me, and then we have to work out whether it was a process, procedure, or just an honest mistake, or whether somebody's done something that they shouldn't have done. We look at compliance with the guidelines, we look at our usage, we look at our appropriateness, we look at specimen documentation, as Jane said earlier on about looking at our specimen errors, labelling, patient identification, documentation, signatures. So I run audits on all this sort of stuff. So where forms aren't filled in correctly or there's tube labelling issues, I will put in an error associated with an episode for that patient, and that's then available for an audit trail, and I report those to our hospital transfusion committee. If we pick up anything that's becoming irregular, so things like signatures are missing on documentation, we'll look and maybe nut that down a little bit closer. So, well, is it coming from anywhere in particular? And then if it's coming from, say, a particular ward, say for example emergency, failing to the RMOs failing to sign off on the bottom to say that the registered clinician will then approach the lead person in there, the director, and say that we've got a problem here, you need to fix that upstairs. And that's how we fix those things. So audit's very, very useful for these sort of things, and NATA requires you to do loads and loads of audits in order to pick up any problems and to identify issues early and fix them. So we have adherence to a strict specimen labelling policy, decreases the incidence of erroneous blood grouping of blood bank specimens. And this was a report that was done in 1997, And you can see there the findings were that samples that contain a labelling error are 40 times more likely to be from the wrong patient. So conclusion was zero tolerance. So we operate that in the transfusion lab. So someone will say, oh, you're being over pedantic, it's ridiculous. I missed an E off the end, so what, cares? We all know it's the right patient. But what it was saying was because they didn't take attention and care in that situation, that there's quite a good high degree of possibility that they basically have made another error somewhere else, and maybe it's not the right patient. Maybe it's someone else with a similar sounding name. So that was a report from 1997, and that's why we get transfusion samples now. Any discrepancies, we reject them because we can't guarantee that that's the right patient, and we do have a zero tolerance to that. So safety is everyone's responsibility. So be absolutely sure that the specimen collected is from the correct patient. Be absolutely sure that the specimen collected is labelled as that patient. Even more important, probably than the first. So that's the thing, because you're not going to, you get that wrong, and you are up the river without a paddle there. So strict adherence to protocols ensures patient safety, and correct product to the correct patient at the correct time. So I've actually been on a ward once where I was having a conversation with a consultant about a patient of his, and I saw in the background someone take some blood samples and they brought them to a bench, and then someone asked what their weekend was like, and they just turned and said, oh yeah, that's fine, really good, blah, blah, blah. And someone threw some patient notes down right next to her, on top of some notes that she, near where she was. She looked over after she finished her 10-second interruption, opened the case notes and just put the labels on the form, and then started to label the tubes. And I had to interrupt my conversation. So I think that was the wrong patient you've got there. And she looked at me rather belligerently and said, oh, I don't believe so. I think I know what I'm doing. And I said, yeah, but you didn't see the person come down next to you and put those notes on top. And then she turned around and had a look, and then horrified look on her face. And then she proceeded to blame the person for putting the notes down. Really, the problem here is hers, because what she should have done was labelled those samples at the bedside, come away from it, not labelled it somewhere else. And that's a big policy at the hospital, that we do label at the bedside right next to the patient, so you're not distracted by anything else that's going on. So it's as easy as that. And that's basically how a lot of these mistakes happen. So, interrupting someone in the middle of a process, and then their mind just deviates from what they're doing, and then they basically lost their train of thought. And so that's really, really important to leave people alone when they're doing these sort of critical tasks. So we do a positive patient identification, as I said. Identify the patient by direct inquiry. Please your full name and date of birth. You don't walk up to them and say, John Smith, date of birth, blah, blah, blah. If they're in a delirious mood or going in and out of consciousness, they may answer yes. They may have not a clue what you've just said, and that is just not the way to do it. So what you have to rely on then was you would go to their bedside and look at their name tag and take your details from them at that point, from the actual wristband that they have on there, and identify the samples. Otherwise, you will ask them to repeat their full name and date of birth, so it matches the request form you have. The unconscious and identified patients are identified following the unknown patient protocol. So if we get someone in DEM, for example, we've had traumas before, multiple traumas, so they're obviously conscious when they come in. What they will do, emergency, is they will allocate, on the absence of any details or any ID on them, they will give them an allocated number from emergency. And basically that's a unique number that they use upstairs, and then they've eventually identified that patient, those notes then cross-referenced and put into the correct patient's files at that time. So there is actually something in there. And as I said, all samples are labelled at the bedside and at the time of collection. So I hope. Give me a second.
Mike, just while you've stopped there, perhaps people would like to just stand up and have a 1 minute break or so, just to stand up and do some jumping jacks, take a big breath, walk around, and then we can continue for the rest of the
Sure.
the lecture.
There's not many more slides, so.
Okay, thanks, Mike.
So I've got a lot of out of breath people at the other end now, I take it, Jane, so with all their star jumps and whatever, so.
And
Okay.
also it gives you a chance to have a bit of a breather too.
Yeah, absolutely. So I'm probably going to hide in here until it's a 3-hour lecture as well, Jane, just to catch another hour out of it.
That sounds like a good idea. Thank you.
Okay, so we've got examples of errors in transfusions. So anyone thinking of changing their Friday night plans and having a nice lie down and having an infusion of alcohol rather than, say, going into town or up to Sporties or whatever, we don't offer that service here. Whether they do in Russia, I couldn't tell you, but yeah, that's just one of those things I think a lot of us feel like at home is having a breather and a nice little drink, hopefully not from a bottle or a whole bottle, but just having a nice little drink to relax. So if we go into the sort of examples we get, so for one we have patient A. So we present, these are real life cases, these aren't things that are made up. So these are taken from various reports and that. So patient A was presented for full blood count. As I said, not at this hospital, hemoglobin was low. Unexpected, but patient on treatment that could have had that effect. So a transfusion was ordered, and patient B were presented for a full blood count, and the results were normal. Unfortunately, the 2 FBC specimens were labelled as the wrong patients, A from B and B from A. So the tubes were labelled absolutely perfectly for the patient. Unfortunately, these were labelled after the blood was collected by the phlebotomist, and both patients were being bled simultaneously, side by side, and a common bench was used to place the unlabelled tubes. So what they'd done is they'd gone down, put the tubes down on a bench, then bled the other person, put them down on the bench, and then they'd gone and mixed them up which way they were actually going to do them. One of the things, as I said earlier on, is we don't have a common bench now, and exactly that case I told you about where the nurse brought them over to an area where their notes, but that's a common bench. What we do insist on is it is by the bedside, and this is how easily it is done. So very, very easily occurs. And what happened was that patient A received a blood transfusion they didn't require, so they were the patient with the normal results. And this was soon after the first bag was commenced when the error was detected in the laboratory. So the patient apparently suffered no ill effects, even though hemoglobin had been around 145 grams prior to his transfusion. So it's probably about 155 by the time he received the unit of blood, and patient received a transfusion for his low HB at a later date. But you know, that's one you get away with if you were going to look at that from it as an outsider. But obviously within the profession, that's a big no-no. We don't want to risk that, because obviously the issue is here that if they'd have had a group and hold taken on that before, we've already blood grouped that individual incorrectly as well, so we may well be giving them an incompatible transfusion. So that was just on the basis of an FBE. When you look at ABO incompatibility, as I said, the greatest risk is for the transfusion recipients, obviously, the ones receiving the blood. You can get massive intravascular hemolysis, and it's a mismatch between the donor cells, as we've said, and the patient's plasma, and potentially fatal. And the most common cause, as we say, is a clerical error. And example 2, we had an elderly lady, not to our DEM, presented to DEM with signs of anemia late Friday evening. Full blood count was requested. Hemoglobin returned as 55 grams per litre. 4-unit cross-match requested. Patient admitted to the ward, and the hemoglobin checked on the following Monday, and the result was 210 grams per litre. So obviously, first thing you would think of when you saw that is there must have been either we've got a hemoconcentrated sample, or we've got a sample error, and that's what occurred on this occasion. There was a sample error, query drip fluid contamination. So they've taken the blood sample very close to a drip, where drip's running in, and what's happened is you dilute it out. And they were asked to repeat it, which is what we do regularly here if we get a result that we're not expecting. And even though they were advised by the laboratory to send a repeat, they didn't do so, and then they're left with the consequences of a hemoglobin of 210 grams. Which is very, very dangerous. As I said, you can get into TARCO, that's circulatory overload, huge stress on the heart and the organs of the body, pumping that sludge around. Pulmonary edema, which is a risk of pushing plasma out, high risk in elderly, infants, and in patients with severe chronic anemia. potentially fatal, and you get a huge increased risk of DVT. So obviously imagine you've got a high concentrate of red cells going down into microcirculation. The chances of clotting there where it gets stuck because there's just too high a volume of red cells, it is like a sludge. And transfused cells have been shown to basically relate to a sludge as well when they've looked at these sort of in-vein processes that they do, which my sort of brain escapes me now what they're doing, but certainly these angios and stuff like that, where they have a look and see this sludge of these red cells, transfused red cells, when they mark them, of how they behave. They don't behave like your normal red cells, so there is high risks associated with that, and actually blocking up your microcirculation. So as I say, we read lessons, we report, we record, we review, we share our conclusions related to the near-miss events, reducing errors by learning from our mistakes, constant review of the process, and we encourage reporting and questioning. We don't try and hide. As I said, it's really important that we come clean about when we've done something wrong or something has gone wrong. One of the guidelines that we do, as I said, the patient blood management guidelines that we have, which is the best and safest blood is your own, is the argument. But basically, these guidelines are on the National Blood Authority. Jane will make these sort of slides available to you for, I believe, in your talk, so you can actually go in and have a look at those things. There's lots of really interesting information in that patient blood management portfolio on the MBA. So about all your blood products and how they're using the management program, one unit transfusion policy. So we try and minimise the amount we transfuse patients, for example, appropriate blood use, best practice tools, all these sort of things are on there. Worth just having a browse on there and having a look. There's the BloodNet portfolio that I was talking to you about. That's our interface with the National Blood Authority. So we do all our ordering and such like on that system. So we order all our blood products, all our box products, so all our fractionated products and things like as well as recombinants. So all our products like albumin, which come from patient plasma, prothrombin, which is a reversal reagent used for patients with warfarin, bring INRs down. So all these sort of things that are knocking around in the background, a whole host of products that we keep, anti-Ds and as I said, a whole gamut of things, factor VIII products and stuff we're required to issue, IVIG, so intravenous immunoglobulins. All this sort of stuff is managed through this BloodNet portfolio under the guise of the National Patient Blood Management Program and the National Blood Authority. So they're keeping an eye on us, we're keeping an eye on what we do and what's going on in the wards, and hopefully there's nothing much or nothing too bad to report. And then we have a look at things like alternatives to transfusion. So, our thresholds used to be that, hemoglobin's greater than 80, we're still transfused with a unit here or 2 units to get them over 100. That's all gone by the by now. That went a long, long time ago. As I said, they were found from various studies done that the red cell transfusions weren't necessarily healthy for you. They should only be given in very strict anemic situations. So hemoglobin's, for example, our ICU have found to do much better. Our patients where their hemoglobin is left to not to go no lower than 70. So we're allowing above 70, below 70, then we might give them a unit. But then they only give them 1 unit. They don't try and get them up to over 100, which was the old practice, the old sort of unknown about we find these things out later, the risks. We can give patients iron if we know in advance that or even if they're starting to drop and we can identify their iron levels low, we can give them iron rather than give them transfusion. As we said earlier at the very beginning of this talk, we don't know what's in those that cytokine soup, if you like, what we're introducing into them. So iron's a very good way of marshalling that anemia if you can treat patients. EPO, erythropoietin, again, something that we look to try and get them on the EPO to try and stimulate their red cell production. Cell salvage don't really do a lot of that anymore. They do them in some places. As you said, the safest blood is your own blood. And what the idea behind that was that any major surgery, basically any blood loss was put into a vacuum, then treated and cleaned over and shoved back into you through a mechanized machine. They don't do a lot of that anymore. They do it in massive trauma where they can, and we do have the ability to do those sort of things. But a lot of the techniques, surgical techniques, as I allude to on the next one, are very, very good now, and there's very little blood loss, thankfully. So there are, we don't really use that technology in the same degree anymore. And obviously our patient blood management tool, which I just highlighted there, we have those books and brochures, if you like, that guide us on what we should be doing. And we can sometimes pass those on to clinicians if we feel there's a better outcome or a better option. And so things like that are really important, that we have these manuals to refer to. So we don't know everything. We always, I'd say to people, I don't know everything. Always willing to learn, and as I say, protocols and procedures teach us things, and the thinking behind them as well. I said sometimes it's from errors, and sometimes someone's had a really good idea. But that's the sort of things we have at our access. If I can leave you with one final thought. So that's it. Any questions from anybody?
Just while we're waiting to see if, well, sometimes people prefer to type their questions rather than ask the mic, so we do need to leave a little bit of a lag for that. If anybody does have a question that you're typing, perhaps if you could use your hand up icon, just so that we'll wait for you.
You don't have to be necessarily about anything on here. I'm quite happy to entertain any questions on anything else you have any queries about around blood transfusion or the profession or anything. I don't mind. So I'm here for at least another 15-20 minutes if you want.
So Mike, just while people are perhaps thinking about questions, where do you see the future of the transfusion laboratory going? How do you think it will change sort of in the next 10 or 20 years, or 10 or 15 years?
Yeah, I don't know, Jane, to be honest. There's a lot of work being done on the background. I mean, there's still after the Holy Grail, which is as you know, and you've seen probably tons of papers written on the Holy Grail of the unit of red cells that is basically compatible with every scenario and every situation, where there's been lots of work and some business around that. Trying to I think there was a place in Bristol, I seem to remember, that was doing some work on that, actually finding some red cells by using stem cells. So actually producing red cells that were basically universally able to act as a universal donor, if you like. So reducing the stress, if you like, on donation centres. And there's been a lot of work on that. And the idea behind that was not to replace it, because it is rather laborious work, but was basically to help alleviate the pressures on these donors. And I've heard horror stories, and I say horror stories, but I must be pretty guilt-ridden horror stories, I think, where O-negative donors, for example, where there's always a lot of pressure on that, are phoned almost on a daily basis to donate blood, because as a profession, we're not necessarily doing the right thing by looking after those units. We're using them in the wrong scenarios rather than as emergency settings. We've done a lot of work in that area, so we're trying to reduce our reliance on that. So we've been, as I said, we don't waste much, and we try and use it where appropriate. So O-negs for O-neg patients. So things like the stem cell work, that's got some, whether they can make that a manufacturer process, it's a steamroller, and stop this donation, this reliance on that, and make them perfectly safe, so that we have the less effect as possible, so we don't get people having antibody reactions. So that's certainly one, probably more streamlined and quicker processes around laboratory information systems and stuff, a lot more computation. So you've probably heard, maybe talking when you've talked to Gerald, Jane, and stuff about bed, what they call bed to bed, where basically the person comes in, lies on a bed, donates blood, and then it's barcoded and scanned all the way through electronically, all the way to the time when it actually gets to the patient. So we'll barcode it through our system. So the Red Cross, will barcode it into their system. We get it from Red Cross, we barcode it into our system, and then by the time it reaches the bedside and we've barcoded it out to a certain patient, then when they do it at the other end, that barcode on their wristband will then match up with what's on the red cell bag. So there's all these bed-to-bedside innovative processes we're looking at. Things like RFID, so these radioactive tags that they put on blood bags, so that when you flash them into a fridge and whatever, when they're going in and out of a fridge just by the movement of them. So they'll identify the barcode that's left, and so they'll know what time it left and what time it went in. There's all this sort of things knocking around the background. So a lot of procedural stuff, hopefully a bit of clinical stuff, but manufacturing stuff that we can improve on. And I think Gerald told me just on that, I just had a thought. He told me that he watched a very interesting. He was on the blood conference that got cancelled this year because of COVID, the national one. Basically, there was an American military guy that was basically extolling the virtues of whole blood transfusion. So we've gone away from that. And basically, what he was saying was that they've had massive, massive success in treating trauma patients in the military setting, in the US military setting, using whole blood, because they don't have to worry anymore about FFP and cryo and all that lot. Because if you think about it, when we give blood, Jane, we give it as a whole product, and then it gets separated out at the bedside or in the Red Cross itself. And what he was saying was, it makes perfect sense. Why are we separating it all out when we donate it as a whole product? We give it back as a whole product. So you're not worrying about dilution out of, you give someone 4 red cells, you then have to worry about FFP or cryo. If you're giving them 4 whole blood red cells, you're already giving them everything that they're missing to start with. And they said that they've had some amazing results. And Gerald told me, I know Danielle did at home, she was watching it. And he said to me that it was amazing. There was all these, the comments and the chat things coming down the side of the page with people going, "Oh my God," looking at these stats and all this information. And so that there may well be a push, and it's hard to see how, but there may well be a push to put whole blood products back into that area and say that this is far better. But now you worry about, with all these manufacturing processes that people have set up with IVIG and albumin and your FFP and cryo, it would cost these companies millions and millions of dollars that they're in the business of making money, sadly. Whether they're going to be prepared to to look at these sort of things and see processes. Other things, platelets, talking about fridge platelets, putting them in a fridge. They've done studies around factor VIII levels stuff and found that platelet activity as well, that there actually doesn't appear to be any adverse outcome with putting the platelets into a fridge environment, and I'm not sure whether that's on a shaker, to be perfectly honest, but I've seen some work, and there's a big push to make 7-day platelets now instead of 5 days, so we'll cut our wastage down on those, and they said there's no adverse outcome. So there are lots of things knocking around, a lot of work being done. For immediate, that's what I see in the next 10 to 15 years. Whether the whole blood thing takes off, I don't know, but certainly the platelets are coming, the 7-day platelets, and the rest of it, I don't know. That's probably the areas that I see improving at the moment.
Thank you very much. That's really interesting. Yeah, I have seen a few papers around about cold stored platelets, and it is quite fascinating. Yeah. So there's still there's still quite a bit of research going on, isn't there, as to the the ultimate blood replacement, and I guess the advances in surgical techniques and all of that sort of stuff, and the whole patient-focused management and making it very individual and all of that sort of stuff is going to make a difference as well.
Well, we've gone away from thinking that giving red cells is a good thing. It really should be in emergency settings or with people with low HB. So, for you or I, or anything, if our HB drops below 80 and we feel like crap and we feel like we want, the old way of doing it was, I'll get the HB above 100. But we don't think like that anymore. We think, we'll give them a unit of blood and they'll feel a bit better. And that's the way that they operate on that, and only if the patient really feels like they need it. I mean, if you're sitting around a lot and you don't have too many things to exert yourself with, then that probably works. But if they're still trying to go about their daily life and have other responsibilities, then maybe pushing their HB a little bit higher, might have some benefit for them in maintaining as much of a normal life as possible. And you hear some amazing stories. I was only talking to the guys in the lab this week about a lady that had multiple myeloma in the UK that I remembered, and I've always remembered it. And she was in her 80s, and she had a HB of 80 odd and a platelet count of below 10 for, I reckon, 2 or 3 years, Jane. And they said it's a miracle. How does she keep going? How does she keep going? She's a very sick woman, but she's always bright and cheerful and blah, blah, blah. And this whole story. And then one day the consultant came in and said, "Oh, so-and-so's passed away." And we said, "Oh, how sad. That's terrible." And they said, "Yeah." She said, "I found out something amazing." She said, "I always looked at her and wondered how she'd lasted so long with a trip," because basically that was palliative 2 years before. And she kept going and going and going. And she found out that basically her sister was a paraplegic, and she was the last care of that person. There was no one living, no living relatives or whatever, and she basically took up the undertaking of making sure that her sister was looked after. She didn't want to go in a home or anything like that. So she looked after her for those whole 2 years, wherever the other carer or whatever, or who was caring was obviously not around anymore, and took care of her for those 2 years until she passed away, and then she passed away a week later. So
Yeah,
there's amazing stories of endurance and stuff and around that. And we very rarely transfused her. Occasionally we had to do platelets. You know, she had an accident at home or something like that. But we didn't need to give her products. She just seemed to maintain her hemoglobin around 80, and it was all right for her, and she was fine with that. So different tolerance levels, different things. But yeah, it's just, you know, these human relatable stories you hear about. You know, it truly is amazing working in the profession that we do, that we see these sort of things and we hear about them, and you know, you are aware and consciously aware of what's important and what's not. You know, you probably know better than anybody at the moment, you know, that there are far more important things going on than worrying about that, you know, you've got expired potato chips in the, you know, in the pantry or something like that, that your kids, you know, when your kids arc up and tell you that the whole world's falling in because, you know, the Lego brick fell off the, you know, there's lots of things. It's all about perspective and understanding things and understanding your loss, and appreciating the fact that, you know, you know, life is fragile, and, you know, anything we can do to make it better, and how we approach life and how we approach our job and how we you know, we can improve things is a big thing to take on board.
Sounds like Z has a question for you, Mike.
Yeah, sure.
Go, Z.
Yeah, Mike. I just like to ask. I'm not sure whether this is related to today's content, but anyway, I've been looking through the ANZ SBT guidelines and the BCSH, which is the British equivalent, and I find that the British equivalent is much more strict in terms of their red cell requirements and stuff. For example, irradiation for the British one is 24 hours. And for the Australia one, it's 48 hours. And is there a reason to why is it more strict?
So when you say 24 hours, what do you mean by 24 hours and 48?
Oh, sorry. For the irradiated blood, the British standard says that it has to be used within 24 hours, and the Australian standard says that it has to be used within 48.
That's interesting. I didn't know that. We try and globally, we try and set ourselves up, Z, so we're aligned with best practice worldwide. So it may well be that I'm just trying to think off the top of my head why there would be 24 and 48 hours. Maybe that they're worried about age of the irradiated units over there. They obviously, as I said to you earlier, or to all of you earlier, that their population's much bigger over there, and maybe they're wanting those products to be used much quicker within that environment, so that they get the best sort of outcome for it. But honestly, a day's difference, I'm not really sure why 24 or 48 hours would make it. We certainly don't adhere to that in the sense of, with our irradiated products, we will probably have about maybe 7 to 10 days to use the products. And I would argue that if you're using them on a daily basis or trying to push them through quicker, that's probably not a very good practice. You probably want to be holding on and only giving, as I said to Jane just now and to all of you when you heard, we probably want to be giving them as and when we need to give them to that individual, and we shouldn't be pushing to say we really need to use this red cell unit up or whatever for whatever reason. So my honest answer would be, I honestly don't know why there would be a difference, but I don't think it would be in any way significant, because I haven't been made aware of any requirement for that. And we sometimes have our radiated units sit 3, 4, 5 days in our fridge, and we do run very close to wasting them, but we do use them. So we don't over order either. We make sure we use up what we've got before, or getting close to using up what we've got before we reorder, to make maximum use of those donations and such like. So I don't know. Honestly, I don't know why that would be, but 24 hours isn't a lot in the scheme of things. So it must be just some kind of, you know, the POMs are doing it, so we'll do something different kind of idea. I don't know, but I don't think there's any clinical reason behind doing that, certainly not from our outcome, and I haven't heard anything that worked.
Yeah, I think I kind of forgot to mention that this was for neonatal transfusion, actually, so sorry about that. Okay.
Oh, okay. Oh, yeah. Well, neonate transfusions, that's a different thing. So that sort of makes a little bit more sense. So neonate units tend to only be good for about 3 days when they're irradiated, so sometimes even shorter. So when we get neonate units, they're usually that we usually have to use them within a couple of days. So with 48 hours, that's 2 days for us. They must give them a shorter expiry in the UK. Maybe for efficacy, but we don't do much neonate transfusing here. But they have a much shorter life. They're given a much shorter life thing when they're irradiated. I'm not actually sure why. That's another interesting sort of angle I hadn't really thought of. But they give us a shorter expiry with the neonate stuff, and they probably don't want to see that wasted, Z, in all honesty. So what they're saying is you really should only be ordering that stuff if you're definitely going to transfuse, not just in case. So often with our neonate transfusions, we have to use adult bags because they don't give us enough time to get it in. And they make a call and they say, we want to transfuse them now. Well, we don't have that. Whereas someone like the Royal Children's Hospital would have neonate in Melbourne, would have neonate bags on standby. So they would definitely use them, and they're probably only going to use what they're definitely going to use. They don't want to be binning that and throwing that in the bin very much because like all blood products, they're a precious product. So that probably makes a little bit more sense now. They do have a shorter expiry, but it's really about making sure you use the products at your disposal appropriately and in the right circumstances.
Yeah, all right. I think I kind of get it. Thanks, Mike.
Okay.
Okay, Mike, well, we might leave it there because I noticed that it's 5 to the hour and students may have other some sessions that they need to get to. So yep. I'd just like to thank you once again for taking the time out to give this this lecture. I always love it when the guest lecturers come in because it just gives us a really focused, laboratory-based workplace view of what we really only otherwise learn about in the book. So thank you very much for taking the time out, and thank you everybody for listening.
Yep, lovely. Thanks very much, everyone, and all the best, Jane. I hope things keep going in a positive light for you.
Thank you very much, Mike. Okay, I'll stop the recording now.
Lovely, thank you.